All right. So I'm not going to use a microphone, if that's all right with everyone, and make it sort of low key. And I'm also going to use my phone as my slide advancer. So is everyone okay with that? I'm not texting or checking out on you guys. So thank you, Dr. Beasley, for introducing me. So I just finished my master's here in the Industrial Engineering Department. I guess my only remaining official capacity with the UW is I have a research position with the emergency department. So I think that's the only one that I have there, but obviously strong ties through I-PrACTISE. And I'll miss all of you greatly when I end up going to Michigan. But I think there's a lot of great work that we do here that we can potentially start to use in Michigan too. So that's one of my sub-goals of my eight years in purgatory. What's that?
We all
Yeah, cross your fingers. So a little bit about what we're going to be talking about today. So I realized I mistitled the presentation a little bit, but I'll explain why it's not such a big deal and why I made that mistake. But so we'll be talking a little bit about, or actually a lot about, what's called machine learning. And it's sort of if you ask computer scientists what they think about it, they'll say it's like the greatest thing since sliced bread. So we'll learn what is machine learning. Then we'll also look at a little bit how it works, then see how it can be used in medicine or primary care, and then finally wrap it up with a little bit of discussion about what are some of the issues around using machine learning. So what is machine learning? Let's look at some definitions. So I grabbed this one from Wikipedia because that's the greatest source of knowledge known to man, right? So machine learning is a discipline that explores the construction and study of algorithms that learn from data. I think it's a good definition, but it's a little, there's not much substance to it. So it could pretty much mean anything, right? Like you're making an algorithm and it uses data, great. So maybe another definition will make things a little bit clearer. Again, we're constructing and studying algorithms, so great. We're doing stuff with computers and coding. And these algorithms, the goal is that they can improve their performance at some task with experience. And the experience is often measured in terms of data. So it's a function of performing a task and learning or getting some type of experience. And if I were to have to explain to my undergrads what machine learning is, I would say, let's use data to train an algorithm. So essentially figure out maybe some information about the data, and then use more data to test how well it works. So a more concrete example of it is if we had a bunch of maybe tumor samples, and we had information about whoever did the actual sampling of the tumors was able to label some of them and say cancerous or benign. We could use that data to train a model and then eventually evaluate more samples and test how well our model does. So it's essentially like training an undergrad, right? You teach them a bunch of general concepts or you give them some facts, and then they're supposed to synthesize and come up with sort of rules, and then we test them. So a little bit about the mistitling of the presentation, and that's in fact due to, I think, some cloudy definitions that are going on. So if we look at machine learning is sort of in the middle of this big cloud where it intersects significantly with artificial intelligence and statistics. And if you ask the two camps, the computer science folks or the statistics folks, who owns machine learning, they'll both say that they do. So I won't step into that argument, but I'll just say that engineers also use machine learning a lot, so I'll lay a little bit of claim to it too. But artificial intelligence and machine learning are both oftentimes used as synonyms for one another, but artificial intelligence does encompass techniques that aren't used in machine learning, and machine learning will have a little bit more of a statistical bent than artificial intelligence does. And I put human factors over there in industrial engineering. I don't think there's much overlap here yet, but I think that's actually one place that we need to start to look at, especially as we try to push machine learning into new places, and especially sensitive places like healthcare. And back to my mistitling of using predictive analytics, what I actually meant by this predictive analytics is sort of this lassoed region right here. So what we want to do in predictive analytics is essentially take an unknown event that we know some data about and then say, what is the outcome of an event? So if I'm going to go home tonight and I'm going to go on Amazon, am I going to buy socks, or am I going to buy, I don't know, a shipment of Gatorade? And that fundamentally is the idea behind predictive analytics, is that there's something that we know a little bit about. We know that Erkin is a 27-year-old male who lives in Wisconsin and enjoys certain activities like computer programming. So then what's the likelihood that he likes to purchase X, Y, or Z? And so you can use both machine learning, or you can use traditional statistical methods or operations research techniques for these types of questions, but we'll be dealing sort of more with the machine learning side of things during this talk. Any questions so far? Everyone's crystal clear? I'm sure I'm not that clear, but we'll struggle through. So now if we actually look at what's going on currently and see, so what is predictive analytics, what is machine learning, and what's it being used for? If you go on the internet, you'll see that the world's on fire because of machine learning. So artificial intelligence is transforming Google search. If you do Google searches now, every single search that you're using is actually harnessing machine learning in order to help improve the way that it's Google's returning search results. So if you search for maybe I-PrACTISE Madison, in the past it would bring up alternate spellings of I-PrACTISE and separating them as two words. But now, over time, as Dr. Beasley and I have Googled ourselves and sort of looked at the links and clicked on the right links, Google learns that in Madison, Wisconsin, or in people in areas that may be interested in I-PrACTISE, these are the links that we should serve to these folks. And that's actually one of the things that we have to think about, because there's a benefit to that, right? You're giving the person exactly what you think they need, but it also sort of anchors them on a set of information that maybe if they were actually searching for I-PrACTISE in Wisconsin because they're really interested and they want to make a career switch, right?
They want to give money.
Yeah, they want to give money. They wouldn't be able to see us. So this is some of the issues there's actually a lot of discussion about right now is your Facebook news feed and the way it serves you the news from news organizations. Is that, are you just in a bubble of people that are like-minded to yourself because it serves you what you think you're going to like, which is what people like you like, and generally you like people that are on the same political side of the spectrum. So there's some issues with that. And then sort of on the same vein of Facebook, when I uploaded pictures of a vacation recently, it actually said to me, is this you? And it circled my face, and then it circled my girlfriend's face. And what it's doing actually there is looking at all the photos it's ever seen of me and all the photos it's ever seen of Stephanie, my girlfriend, and it builds a model in the back end where it says, I think Erkin looks like this, sort of brown skin, brown eyes, black hair, and glasses. And so when it comes across a photo that I might have uploaded with these general features, it'll pop that back and circle that face for me. And so the computer is technically, they'll say it's learning how to see, but it's more just looking for certain features on faces. And then I'm sure people are acquainted with Siri, so both the processing of your voice when you're talking to Siri, and then also the query results that are returned use machine learning. And then one of the coolest things, I think most of all these things, is the self-driving car. So everyone is pretty much working on a self-driving car right now, but the autopilot functionality that these places are using it's not engineers writing thousands and thousands of lines of how to exactly drive a car. It's actually going out and driving a car and having the car learn from examples how to drive, and then being able to hopefully generalize it so that it can drive us around in the early morning so that we don't have to worry about traffic and sort of look at our Facebook newsfeed instead of actually paying attention to the road. So machine learning is super hot right now. And as you might expect, some of this hotness is rubbing off to medicine. And so people are saying, well, if Amazon and Hulu can predict exactly what socks Erkin's going to buy tomorrow, why can't we also predict what kind of cancer he might have, or if he's going to have diabetes? And I think maybe the logical leap is a little bit tenuous, but there is some underlying truth to the fact that data and evidence-based medicine is a fundamental tenet of the way we practice medicine. So if we're using these techniques that allegedly look for underlying patterns in data, we might be able to do some of this type of stuff. Maybe not exactly predict who's going to get cancer what day, but there may be some validity to using these methods. And this little note is that this is sort of the next layer of, intelligence or systems that may be implemented. And we just went through that with EHRs, and we saw some of the issues that came about because of it. So we need to think very carefully as this might be pushed on providers or systems. How do we do this in a way that is sort of safe and sane? So that's all I had for what is machine learning. Are there any questions so far? No?
I think I'm with you.
All right. So I'll try to not lose you, Dr. Beasley, because you're the one I worry about a little bit.
I'm going to write another letter to Michigan.
Oh no. So before I get my offer from Michigan revoked, but let's move right along to how does machine learning work? So there's a couple different types of machine learning, and I danced around them earlier, but there's three big types of ways that you can supervise the models that are being learned. So one is a classic supervision-based model. So I can give you all the data about some breast cancer biopsies, and I can tell the computer exactly if it was a malignant or benign tumor that this was a biopsy from. And so the computer, if it needs the information, has every single information about all the labels of all the samples, so it can exactly or hopefully approximate some type of relationship between the underlying data that we collected and the actual sort of truth of the classification of the sample. Now there's another version of that. If I were to, say, strip the labels from this data and make it unsupervised, I'm essentially looking for, in this case, some type of relationship between the data that I have. So it doesn't work too well with the breast cancer example, but let's say we have a bunch of customers for Amazon, and we're interested in seeing what are their buying patterns. Now, we could have some professional go through and analyze thousands, I was going to call them patients, but thousands of customers and say, oh, this is a customer who tends to buy more expensive luxury brands, and they like maybe they like buying this type of gift, or they get their home goods from Amazon. And you could have someone go and sort of classify these people, but oftentimes we don't actually know all the different kinds of people that are out there, all the different shoppers. So what you could do is sort of take all the shoppers and take all their purchasing history and say, let's just find groups. Let's figure out how we can group these people and figure out maybe what kind of shopper is Erkin, and see what does he like and what do the people like him like, so that we can serve up what color socks he might like to buy tonight. And that's sort of the unsupervised approach. What we're trying to do is find some underlying pattern, and we're not necessarily saying we know anything about that pattern before we start. And then there's reinforcement learning, which is it's sort of tricky, but it's cool in that a lot of what we're doing with trying to teach cars to drive is reinforcement learning. So essentially, you're not constantly grading the computer when it's driving. You're not saying, yes, you're on the road, good job, yes, you're on the road, good job. What you do is you say, as soon as it deviates from doing well, then you essentially say, no, you have to stop, you took us into a ditch. And then it learns that if I veer suddenly right off the right lane, I'm going to end up in a ditch, so I won't do that. And so it's reinforcing certain behaviors that are particularly good or bad. And then we talked a little bit about the labels. Now, labels can come in a couple different types. So one is classification. So when I was talking about the breast cancer biopsies, we're labeling exactly if the data is, if the biopsy sample is from a malignant or a benign tumor. So there are different classifications here, and we can have anywhere from 2 classifications up to whatever number you'd like. What you could also do is, I'm sure many of you are familiar with regression, or linear regression, is take a continuous value and see what is the relationship between the data that I have and some type of output value. And if you've ever done linear regression, which I'm sure many of you have, that you're doing a type of machine learning, just sort of that specific subset. And then there's clustering, which we discussed before, but looking for groupings, but not necessarily groupings that don't, we're not restricting the groupings to be distinct groupings. We're saying that a cluster may be, you may be able to have 2 clusters, maybe 3, 4. It'll naturally figure out where sort of the groupings are, and then also say what the relationships between groups are. And the clustering and classification ones, there's some overlap there. So if it's a little fuzzy for you, don't worry about it. So really quick little regression example, just because to show that you can do it and everyone remembers back to their statistics course. So I just randomly generated some weights and heights of 50 different patients, and it's not actually a really good fit, but you could sort of try to build a best fit line between these two and then look at what the relationship between weight and height are, so that if we did say we got a patient who was 70 kilograms, we could say roughly we'd expect a 70 kilogram patient to be around 1.65 meters tall. And this is a contrived example, so just remembering that linear regression, something that everyone's done before, is actually a form of this predictive analytics. Sort of marching further down the contrived example path. So let me go back a slide. So for those 50 data points, let's say instead of me randomly generating them, what I did is I was conducting a study, and I had 25 females and 25 males in the study. And I have their weights and their heights, but then I misplaced the sheet, or my EHR crashed, and I no longer have the actual biological sex of the patients. And so I'd like to be able to use that for my research. I need to know that because there might be some fundamental differences between the two populations, but I don't have that information anymore. So what could we do? Well, I could go and maybe try to open up the charts or call up some of the patients that we saw. So then instead of doing all 50 of the patients, I did 20, and lo and behold, I found 10 males, which are blue, and then 10 females, and then I have all the unknown patients that are still, we don't know what gender they are. So then we can try to say, well, based on this information that we have, can we generalize to essentially predict or classify these remaining patients? So just to clear things up, I'm going to put the unknown folks away for a little bit, and then we'll also put this little guy, this male, this male who is sort of in the middle of all the females, we'll put him away for a little bit too, just to make things clearer. So now how should we do our classification? And I'm going to turn to you guys to ask, how would you, if you were telling a computer how to classify between the males and the females, how would you do it? How would you describe to a computer? And just remember that computers are dumb, and they only can usually speak in math or some type of logical expression. So if you want to maybe take, I'll give you guys like a minute or two to talk to the people next to you, and then we'll have ideas as a group. So I'd make a cutoff line right on this 1.65, and then say, if you're above 1.65, we will count you as a male, and if you're below, you're a female. So then we're totally going to throw away this weight parameter for a little bit, or just let's just use height to classify. So that's one way of doing it, just sort of drawing a straight line or a threshold on the variable that we had, is using this height threshold and saying greater than 1.65 male, less than female. Any other thoughts or ways of doing this?
You follow that with weight then.
Yeah.
Re-stratify it.
So then you just do a weight version, right? So we do maybe a line here to separate them. So you could do one line you could do one cutoff on one, and then you could do another cutoff on the other. We could do these two separately, or we could do them together, right? So we could say maybe if you're above 1.65 and you're over, let's call this 65, if you're in this box, maybe you're male. And then if you're not in the box, you're female, or something along those lines. Or if you're in this box, then we know for sure you're male. If you're in this box, because we have a quadrant here, you're female. And then these two are maybe sort of unknown. So I think that the height one is good. And then we can also start to think maybe, what about the relationship between the two of them? Is there a certain relationship between height and weight together that if you are sort of on one side of that relationship, you might be male, and one side you might be female? And we'll get back to that example a little bit. But any other approaches? So we're talking mostly like cutoffs here. So I'll give you guys a couple other maybe approaches that we could use to try to predict. If I put a dot, let's say, right here on the graph, predict what we think that dot, what color that dot should be. So the first one is sort of a fun one. It's called K nearest neighbors. So what it does is it says, you guys give me a K, and we'll start off with K is equal to 3. So what we'll do is we'll look for this dot, we'll look for the 3 nearest neighbors around the dot, and then say, you guys all get to vote on what we think this dot should be. So if we say K is equal to 3 for this guy, we would say there's 2 out of the 3 are red, so this dot should be red based on sort of this simple method. And then you can adjust the voting so that it's maybe the vote is stronger if you're closer to the dot. Again, you're assuming that proximity to one another means that you're similar, and that's an assumption that's sort of inherent in the model. And a lot of these models that we're doing, we're trying to figure out sort of how they relate to one another, and you think dots that are close together should be similar. That's a fundamental assumption that may or may not hold for the example that you're working on. And then if you were to take this and make K is equal to 5, what we'd do is we'd see these 2 extra blue dots. So then we would say this is probably blue because 3 out of the 5 would vote for blue. And so you see that there's a little bit of an issue here, is as you change that parameter, our prediction changes. And that's just due to the way that this model is sort of laid out. So another example is a decision tree. And this is sort of branching logic, and it's very similar to the example that we said, where if the height is over 1.65, then we will say that the patient is male, and if it's less than 1.65, then it's female. And so this is an example that I stole from predicting the probability of dying on the Titanic. So you can sort of follow this down and say, am I going to die? And the answer for me is yes, so I'm going to die on the Titanic. But for other folks might not die on the Titanic. And as a physician, I bet you guys have seen things that are similar to this, right? With your maybe treatment algorithms. So you go through and you ask these questions and then say, does the patient really, should I use this imaging modality, or should I use some other modality for the specific patient, and what would be the best sort of way to treat them too? Is oftentimes you have these algorithms that are laid out as decision trees, and these ways of building models are actually very intuitive for humans and make really good sort of guidelines eventually, but are difficult to train. And oftentimes what we're doing in machine learning is a lot more sort of not useful to directly take the model and use. So that's why the decision tree is nice, because we could actually take the model that's learned and then use it as knowledge in the future. So any questions on those examples? Otherwise, we'll move on to the next one, which is sort of, we were talking about drawing some lines. So we could have drawn a horizontal line on height. We could have drawn a vertical line on weight. but we could also potentially draw a line that is, the whole goal is let's move all of the blue dots on one side and all of the red dots on the other. And so we drew this line, and then we would say, if you're on the top right side of the line, we'll call you male. And then if you're on the bottom left side, you're female. And this is a really basic example of what's known as a support vector machine. The math of it is a little bit more complicated than just sort of taking dots and drawing a line. But that's fundamentally the idea, is that you have this line that separates the two groups. And as we throw dots that we'd like to predict on here, we can actually see where they land on the line or in relation to the line, and then use that to predict the classification of them. So now let's classify. So I have these 6 crosses that I put back on, and I'll just call out. So what do you guys think this is based on the model? Huh? Male. All right. Male. This one?
Probably male.
Probably male. All right, so we'll call this one probably male. What about this guy?
Who knows?
Who knows? Anyone want to take a stab?
This is a bathroom equation.
It's a bathroom equation, yeah. No one wants to take a stab at it? Just yes. You're going to say male. All right, so we've had all males so far, and then this one? Female, and then this one's probably also female. It's also an outlier. I don't know why. I know why I made that data point, because I randomly generated data, but we have a person who has a weight of like 22 kilograms and a height of 1.6 meters. So there are some issues going on there. So now if we actually go and look at the label, so I don't know if you can see the colors, but we got all these guys correct, and this one was indeterminate for everyone, but is actually it's actually male, and it's sort of right on the line. So I'll call it as a hit for us that we actually predicted that correctly. But this guy right here, or this girl, right, I should say, is actually female and is on the wrong side of the line. So what's going on is, just like we had this example back from the very beginning, is that we had a male who was sort of an outsider, or is so far off from the general population that you will naturally have some type of classification mistakes. And an accuracy of 5 out of 6 isn't too bad. We actually did pretty well, considering this is all the data that we were going off of. Now we could do this for all the remaining data. So I just put all the remaining 30 points back up on there. And then if we look at the line that we drew, and we actually just see that we made 5 mistakes out of 30 of them. So just for using those 2 points of data, totally contrived example, it's not terrible. We can actually do some type of prediction about who the gender might, or what the gender might be for these patients. So I was using accuracy to evaluate how well the models were performing. You can use any number of measures to see how well a model is doing. And don't worry about reading this whole table. If you want, I can send you a link to it. It's a great table. But I'd like you to think about, especially for the physicians in the room, think about sort of the tests that you might order. And the tests that you order have sensitivity and specificity. And what we're doing a lot of times with machine learning is essentially building a new test just with data that we have. And we could use, if we wanted, sensitivity or specificity to measure how well the test is performing. There's also other measures that machine learning folks like to use, like precision and recall, and they're related to sensitivity and specificity. Usually I need to refer to this table if I need to think about like what are all the relationships. But pretty much you're looking at the relationship of true positive, false positive, and true negative, and seeing how the model performs on it. And so skipping a little bit onto how we can use machine learning in medicine, and I'll skip these other examples about imaging and personalized medicine, and also continuous remote monitoring. If you have questions or would like to talk about those, just flag me afterwards. And I'll reorder the hospital, this 2 research projects that I've worked on. So we'll skip this hospitalization prediction project and go directly to inpatient admission forecasting. So this is my work that I do in the emergency department. And we're essentially looking at the fundamental question is, can we predict at time of triage if a patient that came into the emergency room will need to be admitted. And so usually, if you ask a physician at time of triage, they actually have a pretty good sense of if a patient may need to be admitted or not, and they're fairly accurate. We haven't actually gotten approval because you need to, that's a human study, we'd need to get human study approval to actually ask that information and collect it as part of our study. Ideally, we do that in the future. But the thought is having a physician at triage or having a person do this assessment would be great, but that's taking away a person from actually doing care. So can we do this on the back end and have the computer do it? And what we actually don't want to use this for is use this prediction to influence the care in the emergency room. What we're actually interested in is for bed planning purposes. So when the patient is done being treated in the emergency room, they'll need to wait for a bed, and can we potentially alert the people that do the bed planning in the hospital to say, in 4 hours or 4 or 5 hours, you may receive this patient, just be aware so that you can do your bed and capacity planning for that time. So a little bit about the emergency room data that we have from UWHC. We have 3 years of all 3 years of patient encounters from 2011 to 2013. And we ended up using the 2012 to 2013 encounters, which were 91,000 patient encounters. And we used 1 year's worth of data to build out some history because we don't actually have any information about the actual history of the patient in terms of their comorbidities, any chronic diseases that they may have, or any non-ED related visits. So if they visited their primary care physician or if they visited a specialist, we don't know. We only have this very limited perspective from the emergency department. So looking actually at the data that we had for each of the patients, we had sort of information about the patient encounter, so acuity, age, the arrival mode, chief complaint, and sex. And then we have previous ED encounter information, so that's the history that we're able to sort of cobble together from the previous emergency department visits. So if they've been perfectly healthy and they never came to the emergency room before, we'd have no history for them. And then we have also the ED operational state, which is the census and number of patients that are in the waiting room and roomed and such. Yeah, so this is just an example. So what we did is actually said we counted the number of previous encounters with a chief complaint of X, Y, or Z. So it might be dyspnea, it might be like palpitations, it could be altered mental status or whatever. So for every single different chief complaint that was available, we counted the number of times that the patient had visited previously for that chief complaint. So that's a little bit about our data. And then jumping straight to our model performance, we used primarily the area under the receiver operating curve, which we won't talk about. But for accuracy, we used this dummy model for accuracy, so that's had really small, really low accuracy levels. But for all the models that we were dealing with, that we built, we had a range from about 0.69 to about 7.9 accuracy. So you think about every 100 patients, you're getting maybe 80 of them right. And it's not perfect, but if you think about the fact that we're not using anything that maybe a physician would use to make this decision about what diseases does this patient have, when did they last see their physician, and then also with the fact that we might be missing past ED encounters from other places, and there's an inherent variability also in the fact that we don't actually always 100% know if the patient's going to need to be admitted or not, and there's some other factors that are difficult for the machine to understand. So that's the accuracy, but the takeaway from this is, so individually doing this modeling, we can get maybe an accuracy of about 0.8, but what we could do is if we looked at the system, we could say, so our current bed preparation time is we have about 20 to 30 minutes per bed to prepare. So that means an order was placed for a bed, and then the patient ends up waiting 30 to 40 minutes in the emergency room boarding for that bed to be ready. If we look at the time from triage to the bed order being placed, so this is the actual ED care time, we have this big curve down here. And it's sort of nice because it's significantly longer than the time that we have for bed preparation now. So if we say we started to prepare beds earlier, starting at time of triage, what we actually end up with is around 118 extra minutes per patient to start getting beds ready. And so even if you make some mistakes with some of the patients being incorrectly labeled, it ends up washing out, and that's what we're actually studying right now, is sort of what are the effects of that using this modeling at the systematic level. So that's wrapping up that example, and then we'll really quickly go on to some of the issues with machine learning. And I wanted to make this more of a discussion, but I think we'll sort of blow through it as fast as possible since we have 2 minutes. So we obviously have data issues. So if you have garbage in, garbage out, what we were discussing about the favorite number, if you somehow include something like that, and with the subsample of data that you get, it looks like to the model that you can use that as a classifier, then the model will say, yes, this is great, we'll use it. But then when you go to use it in the future, it's going to be garbage. And then there's issues with labeling data, so we never actually know exactly sometimes what the health state of a person is, exactly how sick they may or may not be. And then there's issues with data transformation, that we're taking complicated data that is time dependent and then transforming it in a way that the computers can understand, and there's some assumptions that you have to do that get baked in and limit what the computer can think about. And then there are learning issues, so models might need to be retrained over time. With the examples that we had with the males and females, what happens if everyone all of a sudden switches their diets to maybe just eating chocolate all the time? So everyone's weight is going to go up, and the weight threshold no longer makes sense, or the height threshold no longer makes sense. And we don't easily, with these models, can't easily tap into the existing body of knowledge. So we have medicine that's been around for thousands of years, and we have guidelines and practice that is evidence-based and is taught in medical school, and also through just practice. How do you transfer that knowledge to the computer? Because they're not getting that with just the raw data that you're sending them. And then you have issues of information overload. So if you start doing thousands and thousands of tests, you're going to start thinking that some of the tests that you made were significant, even though it's just due to random chance. So you have to start changing the way you do statistics a little bit to make sure that you're not getting things that are just noise. And then how do we start to incorporate new findings? If we're having many, many discoveries happen from these models, how do you sort of synthesize and use that and incorporate it back into medicine if it can't even be incorporated? And then there's also, I think, the big thing that I'd like to leave you guys with, and also maybe ask you questions about, are the sociotechnical issues. So we can't easily tell what a model is thinking. The models that I showed you, the ways that those models are built, are actually really simple compared to what Google and other places are doing. What they're doing is so abstract and so sort of esoteric that if you look at the way the model is trained, you can't actually take anything back out of it and get knowledge out of it. So how do we either query those models or figure out what might be the decisions that it's using to make that classification, and how do we translate it into knowledge? And how do we actually think that we can use it to help enhance a physician's practice? So does that mean it's going to be sitting in the EHR? Is it going to be constantly monitoring? Is it going to be something a tool that a physician uses and queries? And fundamentally, how do the physicians use it? And how does it fit as part of the system? So I think I'm over on my time. If you guys like to have a discussion afterwards, we can. Otherwise, I will turn it back over to Dr. Beasley. Thank you very much.
Thank you very much.